Today on MIT's Data Nation, we're diving into one of the most fascinating, fast evolving, and controversial areas of science and society: psychedelics. I'm Liberty Vittert Capito, and along with my co host, MIT professor Munther Dahleh, joining us are two guests at the forefront of this space. Dr. Nicolas Langlitz, a cultural anthropologist and historian of science, whose work explores the revival of psychedelic research and the tensions between scientific objectivity and subjective experience. And alongside him, we have Dr. Joshua Siegel of NYU, an MD PhD neuroscientist whose research looks at the brain on psychedelics. What's actually happening underneath the hood of the skull, and what might that mean for mental health, consciousness, and beyond? So together, we're really going to explore the intersection of data and altered states. What does the research actually show about the benefits of psychedelics? How are we measuring things like therapeutic outcomes, perception, cognition? And are we at risk of letting hype get ahead of the evidence? This conversation is about science, culture, and the truly deep questions these substances raise. Not just about healing, but about what it means to be human. So, Nicolas, I think I'm going to start with you with this. There's an enormous fear and stigma around psychedelics, even as many more people turn to them for mental health treatment, and as we hear more and more stories about how valuable they can be. Is there anything to this fear and stigma? I mean, are there still issues with this research, or are there maybe types of psychedelics that there should be problems around? Or is this really truly just a life-changing magical cure?
Well, look, I mean, I think if you look at the history of drugs, stigma usually comes about when particular drugs are associated with particular people, and those people have fallen into disrepute. So in the case of psychedelics, the stigma goes back to the 1960s, when many psychedelic users, or at least the ones who were publicly visible, were college students, countercultural people, hippies. And if you don't want to become like them, you shouldn't be taking psychedelics. I think that has changed pretty dramatically. And in that respect, I think we've seen a very significant destigmatization of psychedelics in the past 1 or 2 decades. Now, there is another dimension to this, which is that in the research field, there is a persistent problem with the stigmatization of psychedelics and their researchers, in that most psychedelic researchers have had their own psychedelic experiences, and many of them only got into this line of work because they had these experiences, and the experiences left a deep impression on them. And if you consider that objectivity has been established as the scientific norm and value since the mid 19th century, there is a widespread concern that the field lacks objectivity and that there are too many enthusiasts around. And that is a very, very interesting question to me, which also affects the repression of self-experimentation, the question of whether psychedelic therapists should be expected of having taken the psychedelics that they administer to their patients, because otherwise they can't understand what their patients are actually experiencing, whether they should have undergone therapeutic training analogous to psychoanalysis, where every psychoanalyst undergoes their own psychoanalysis that has been standard since the days of Freud. So shouldn't every psychedelic therapist undergo psychedelic therapy as part of their training? So, that raises a lot of questions, and I think there is no straightforward answer. I do think that the stigmatization in that context is justified, but at the same time, there is no simple answer to the question of whether or not psychedelic researchers should free themselves from these allegations by simply not knowing what they're talking about and what they're researching.
Josh, what are your thoughts on that?
Well, I do want to add two particular things. One is that, of course, taking a mind altering drug and acutely being in a situation, particularly when it's combined with other drugs, where your thinking has changed, your perception of reality has changed, that can be a dangerous situation when you're not in a safe or controlled environment. And so that's one serious consideration. And all the research that's being done, every research study that's been sort of approved by an IRB and followed institutional protocols has been with careful oversight and guidance and monitoring. And so that doesn't directly translate to people going out and using these drugs under very different contexts in the wild. And then the other thing is that particularly for people who have predisposing risk in terms of psychiatric illness, schizophrenia spectrum illness, or bipolar illness, there's clearly and maybe even some others, there's sort of a risk of a spectrum of lasting psychological negative effects of the drugs. Now, that has to be weighed in balance with the really clear positive signals that are coming out of clinical utility of these drugs. But it's important to not forget about those real risks.
If I may add to that, I think another fascinating bioethical challenge is that at least part of psychedelic therapy is understood as psychedelic assisted therapy or even psychedelic assisted psychotherapy. And that means you have a situation in which the risks associated with the drugs are compounded by the risks associated with psychotherapy, because psychotherapy is not risk-free. And the drugs are fueling the psychotherapeutic process and are amplifying some of the benefits, but they may also very well be amplifying some of the risks, especially as they shape the relationship between therapist and patient. So the most prominent debate over this pertains to sexual abuse, but I think there's many more subtle dimensions regarding suggestibility, regarding all sorts of minor infringements of patient autonomy, of transgressive behaviors on both sides, both patient and therapist. So I think if psychedelics were to be given market approval and were to be used more widely clinically, I think we would get much more debate about the risks at the intersection of the pharmaco and the psychotherapy.
What about? I just want to make sure that I'm on the same page here. When we say psychedelics, what do we mean? Is this MDMA? Is this mushrooms? Is this ketamine? Is this what do these include that have been shown to have benefits that we're really studying here?
I'm glad that you asked that. I was just at this Gordon Research Conference on psychedelics, which was a big coming together of psychedelics researchers. And that was one of the biggest ongoing arguments is what terminology should we use? And there was not a clear consensus. And there's like the lumpers and the splitters. And at least when I'm talking about psychedelics, when I say, psychedelics, I generally mean classic psychedelics, which is drugs that affect the serotonin 2A receptor, or sometimes they're described as LSD-like psychedelics. So psilocybin, LSD, DMT, ayahuasca, peyote. MDMA works differently. It increases serotonin and dopamine in the synapse by blocking their reuptake. Ketamine works completely differently in terms of its first level neurotransmitter target. It's an NMDA antagonist. So overlapping effects and maybe overlapping benefit with psychedelics, but different mechanism. And then ibogaine, also not a classic psychedelic and more similar to ketamine, but has a variety of other targets, including the opioid system. So It's
So
hard
when
to.
we're talking about the ones that we have data for, is
Yeah.
it these LSD-like ones that you said at the beginning?
Yeah, most of the recent clinical trials have been with psilocybin, and that's what I'm talking about when I say psychedelics. Or there's been a number of trials with MDMA for PTSD, and that's not what I'm talking about when I'm talking about psychedelics, but it is its own sort of emerging area.
And there is also ketamine for depression, right? So you do have clinical trials for all these different classes of substances, but most pharmacologists would stick to Josh's categorization of only considering the 5-HT2A agonists as proper psychedelics, whereas ketamine and similar compounds like PCP and so on are dissociatives, and MDMA and similar compounds like MDA and so on, various analogs that are currently being produced by startups, are considered entactogens. So you do have a more fine-grained taxonomy. It's just that in popular reporting, they're often all lumped together. And then I think there is also in some corners of the research field, especially in the therapy context, people also occasionally lump them together, partly because they're used in a similar fashion to augment a process which is essentially psychotherapeutic. I mean, that's being done with the classical psychedelics, with MDMA and with ketamine. And I think it would be quite interesting to look at the different psychopharmacological effects of these different kinds of compounds actually shape the therapeutic processes, because I mean they're different animals, right? So I think that the lumpers often overlook that it is not the same thing if you're doing drug-assisted therapy with a person on MDMA or with somebody who is tripping on DMT.
Just let me follow up a little bit on these things. And I want to make a comment that allowing psychoanalysis using psychedelics was on the ballots this year in Massachusetts, right? And as a result, I ended up being invited to multiple events. But I walked away not convinced. And part of it is, well, okay, what are the true experiments that have been done for these drugs that establish their efficacy? Have been randomized control study. How do you measure the outcomes? I know Josh does fMRI, so you're tracking some of the biological changes. So tell us a little bit more about the actual evidence. What, from a scientific perspective and a data-driven perspective, what do we know without all the sort of hoopla around the topic?
Well, I mean, on the one hand, the clinical evidence has continued to accumulate. I mean, you have this situation where there was probably 40,000 people who were given a psychedelic as part of a clinical trial before the year 1970. And then everything was shut down. And now there's been this, reemergence of psychedelic research. And just in the last 20 years, now we're looking at something like 2,000, 2 or 3,000 individuals who have participated in a psychedelic clinical trial. And in the trials with depression, the results have been pretty consistent that there's a pretty substantial antidepressant effect, and pretty rapid and often lasting for, weeks, maybe months. There are limitations to that, the biggest being that we don't have good sort of blinding, in that you give somebody either the drug or the placebo, and they're going to know which they got. And if they have a, bias and expectancy, that's going to influence their response. But, even still with that issue, if you look at how people have responded who have varying severities of depression, anxiety, compared to other treatments in psychiatry, the evidence is pretty compelling. So to me, the numbers are the most important thing. I mean, that's why there's so much enthusiasm. That's why, the FDA is now looking at fast track designation and maybe approving psychedelics in the next couple of years.
And in terms of the actual biology and how they function, do we have a good understanding of why we get the outcome that we get?
Yeah, that's been a really interesting story. And the first thing to point out is that psychedelics, we know the primary neurotransmitter target of, LSD and of psilocybin is the serotonin 2A receptor. So, we know what receptor in the brain they're working through, but the story that's emerged is what happens then. So it binds this receptor. What's going on? Why, what can we understand about why it's producing these very unique subjective effects? What can we understand about why it's potentially antidepressant? And one story is this idea of, the technical term will be the neurotrophic hypothesis, and this is this observation that antidepressants in general seem to increase plasticity in parts of the brain that are related to, emotion and behavior and mood. And psychedelics are not an exception to that. In fact, they very rapidly induce plasticity in these emotional circuits, and very powerfully induce plasticity. So that's been, unpacking that story and all of the nuances of what that means, where's that happening in the brain, what are the implications. But the plasticity story has been really fascinating. And I mean, it is to me pretty compelling because, for example, in animal studies, they'll block the plasticity effect of these drugs, and then you don't see antidepressant like responses. So it seems to be really critical for why the drugs are therapeutic. The research that I do, which is more on the human biomarker and brain imaging side, has sort of given this interesting complementary story. And it's sort of gradually been growing and congealing. I think the first step was just in the last, in the 21st century, starting to understand the default mode network, which is this collection of brain areas that seems to be really related to creating the sense of self. And what it does is it creates your sense of who you are and how you relate to your world. And, the realization that that network is probably intimately related to a lot of psychiatric illness. And then, the story with psychedelics has been this realization that essentially they are sort of selectively scrambling the default mode network transiently and taking this system that's normally very structured and ordered and highly communicating and putting it into essentially a state of disorder. And that seems to strongly correlate with people's subjective experience of things like ego dissolution. And ego dissolution means your ego, your sense of me as a distinct entity separate from the world, often dissolves when people have a high dose of a psychedelic. And then there's these other, interesting dimensions of the experience. Often there's a sort of spiritual component. And then, one of the dimensions it's called ineffability, which means that people often describe that the experience is difficult to describe. So that's another one of the classic dimensions of a psychedelic experience. So, the observation with neuroscience has been that the loss of sense of self has a pretty clear biological grounding. It's not some mystical thing that's happening in the soul. I mean, maybe you can say that it is, but at a biological level, it's a desynchronization of these sort of highly evolutionarily conserved systems that create our sense of ego and sense of self. And the thought is that has some important implications as well for why the drugs are therapeutic, is that it opens up this greater flexibility in the sense of self and both identity and also habits.
And we should add that there is a heated controversy within the field over the relative weight of these two explanatory models regarding the therapeutic outcomes, right? There is basically one school of thought that says, well, it's basically all driven by neuroplasticity, and therefore we should design novel drugs that get rid of all these mind-altering side effects and just amp up the neuroplasticity enhancement. And then there is the other school of thought that says, well, if you don't have the mind-altering side effects, then there is no therapeutic effect because, for whatever reason, because the intensity of the peak experiences, the ego dissolution is really what's driving the therapeutic efficacy. Or, if you're coming more from a psychoanalytic perspective, then maybe disrupting the default mode network, allows you to access more of your unconscious materials and to reimagine who you are. There's like different understandings of this, but they do boil down to a pretty intense and emotionally charged debate within the field.
But before we leave the sort of the discussion about clinical studies and maybe behavioral outcome instead of the biological outcome, so I understand that it's not really that easy to sort of create a placebo effect and entirely a randomized experiment, but you could still see the clinical outcome. And Josh, you mentioned sort of improvement 2 to 3 weeks, even more. But I'm asking now, have we tracked those people over time afterwards? What has happened? Because part of the recommendation, the language that people use is that, you go on a journey, a controlled journey with somebody, and so there's an actual sort of control in the way you do this, and then somehow you don't have to do this again. But in fact, after a few months, maybe you have to come back and do this again. What is the compounded long-term behavior of someone who receives these kinds of medication or this kind of drug?
So it seems pretty clear that the benefits of psilocybin for depression last longer than ketamine. Ketamine, we classically say you get about a week of benefit. With psilocybin, it seems pretty clear that people who respond get benefit for, we'll say, maybe a month, maybe a couple months. Beyond that, there are some open label studies that say, we followed these 20 people who took psilocybin and a year later they were better. So psilocybin works for a year. I don't think it's that simple. The studies that are going on right now, the big phase 3 studies that ultimately will be used to make the decision to approve psilocybin by the FDA, they are doing redosing where after your initial dose, you can get a open label dose 6 or more weeks later. So that'll provide a lot of useful data on how long it takes people to relapse, on how beneficial it is the second or third or fourth time, which honestly we really don't know at this point. And we talked about some of these neuroplasticity theories. It's not completely unreasonable to think that maybe you won't get as much benefit from the second or third or fourth dose, but we're going to find out, within the next year or so. So, at this point, I think it's fair to say longer than ketamine, maybe, a month or more, but we don't know exactly what it's going to look like in terms of how long the benefits are and how often people will need to be redosed, how much they'll benefit if they got a benefit the first time. Are they likely to get a benefit, a few months later?
So if you want a glimpse into post-trial future of psychedelic assisted therapies, I think the place to look is Switzerland, right? Because the Swiss have run this limited medical use program since 2014, and they have been dosing their patients repeatedly, sometimes over more than a year, 2 years. I think the average time difference between dosings is about 3 months, but it is not a controlled trial. So they basically do this in a patient-oriented way. If the therapist thinks that they would benefit from a higher frequency, they get a higher frequency. And if they think that they need more time to integrate an experience, they do it at a lower frequency, which means this clinical work that the Swiss have been doing does not generate data which is scientifically particularly analyzable, but it is a very valuable clinical experience which they have been accumulating over more than 10 years now. And it is not a golden bullet, right? It's not like you dose people repeatedly and they get rid of all their mental health problems and suddenly they're, perfectly fine. It's a long-term process. They get better on some levels, but, they still need some form of care and so on. I think, this golden bullet narrative that's sometimes floating around in media reporting, that is definitely not going to materialize as we move from clinical trials to clinical applications.
But I think that kind of the phenomenon that you talked about earlier, this positive feedback, psychedelic people are the best fan of psychedelics, or the way you phrased it, or they're most enthusiastic about that. You hear that in these anecdotal meetings, where people are brought in and they'll tell a story, about how depressed they were and how life have changed, and they talk about only once or twice that they did this. And so I think that the worry that some of us have is there's a combination of selective reporting of the positive results and not necessarily the negative parts or the not so great results, plus an economic opportunity here for creating for selling a drug, and also for creating new types of therapy for people to kind of utilize, that is going to take us in a direction that is not necessarily the best for people. What do you think about that? Is that a serious concern, or we are beyond that at this point?
Can I throw something in about this bias question? I think there is also a question about who the people are who are hyping the drugs the most. And in my experience of researchers, it is not the case that people who have taken more drugs, who have had more psychedelic experiences, are the ones who are hyping the substances the most. There is also a type of researcher who has been in this business for decades now. And because, the revival of psychedelic research really goes back to the 1990s, and there are even a few people like, medicinal chemists or pharmacologists working with animals like Mark Geyer, who have been working throughout the so-called dark period when prohibition supposedly repressed all research. They are not the ones who are doing the hyping. I think that the people who tend to be the most problematic as far as the hyping is concerned are people who have only had an experience quite recently. And because there has been such a wave of media reporting, and the field just gained so much steam in the past decade, there are a lot of people out there who had experiences quite recently, a couple of years ago, then decided to jump onto the bandwagon and get into the research. And obviously they also benefit significantly in terms of getting grants and media attention and so on by overselling the value of the substances they're studying. And, I think that's where the problem lies. So it is not that being experienced or not being experienced determines whether somebody loses their objectivity or, loses their sound judgment of the substances.
No, I totally agree. Actually, I want to say that increased marketing and the fact that it made it to the ballots in Massachusetts, to me that is an institutional push. It's not a one-off person who had a good experience who's very excited. That doesn't get it on the ballot. To get it on the ballot, someone is putting quite a bit of money behind it, And this is the knee-jerk reaction I'm getting, is that someone out there sees a big opportunity for legalizing therapy with psychedelics. And I'm getting the reactions that I don't want it. But I'm asking you, should I have that knee-jerk reaction?
But sometimes that person who's driving the institutional push with money is also a billionaire who took psychedelics at Burning Man, right?
That is
2 years ago, and then decided that is the future, and now they're investing in it big time and so on.
That's exactly right.
Can I ask a question? I will actually caveat this with, I've seen with two people actually, this being sort of a life-changing thing for them, regular treatment that they go to. I wonder how much of this bias and this worry and how sort of the discussion around this is because it's an illicit substance, and also because it's a really expensive treatment. So the friend I have who goes and gets ketamine treatments at the doctor's office, I think it's $1,000 for every treatment. Whereas you then have these companies like Mind Bloom, who are letting people take ketamine at home and in what seems like very high doses to me for a much, still expensive, but for a much less amount of money, with the idea that they're democratizing this type of treatment. And then, you have people say, well, it's just actually sort of an easy way to get an illicit substance, to get drugs. So how much of this, this sort of fear and discussion and worry is just because it's a drug, an illicit drug?
There's so many factors playing in here. The fact that it's illicit, the fact that there's an enormous swelling of interest and excitement about it. Some of the people who are paying for lobbying for some of the legislation are the same people who are involved with the cannabis lobby, and they want to sell psychedelics in their dispensary and make money off of it that way. But but it's also like we can't classify this as a monolithic beast, because there are large and growing numbers of people who have had positive experiences with these drugs that have failed many of the treatments that psychiatry has offered, and they're in it for completely what you would call the right reasons. I think the FDA is like doing their best to regulate and work with these companies in a landscape that is infinitely complicated politically, socially, particularly with psychedelics. And then you have the recent sort of, I think it's largely grassroots veterans interest, and veterans who have had particularly bad, and having seen VA psychiatric care, I can say that many of them have not had good experiences and have been in a care system that has not been great. And there's been this growth of programs that have done trips abroad for veterans with PTSD and with other issues with psychedelics. And, honestly, I think it's fair to say that they're in it for the right reasons too, because they've seen benefit in people who are seriously suffering and have failed conventional healthcare systems. And then, there is the side of pharma, and actually there is over 100 novel psychedelic compounds that are currently in development by pharmaceutical companies, which is just wild. And they can't all get rich, so that doesn't make sense to me from that standpoint. Particularly when you can, grow like psilocybin mushrooms in cow poop. I was involved with some legislation in Missouri when I was working at Washington University there. And it wasn't any one group that we've talked about that was, working on the legislation. It was multiple partners that are sometimes, unlikely bedmates were coming together to propose some of the decriminalization and propose more funding for research. So it's an interesting place that this psychedelics renaissance has taken us to.
There is also a larger history of drug science story behind both the clinical cases that Josh mentions of people who have been treated with various psychiatric drugs and none of them helped them, and behind this mushrooming of startups that are bringing novel psychedelic compounds, or would like to bring novel psychedelic compounds to the market, which is that around 2010, Big Pharma basically pulled out of neuropsychopharmacology. Basically, all the big pharmaceutical corporations killed their psychiatric research and development pipelines because there had not been sufficient progress on that front, whereas in oncology or immunology, there was a lot of progress, and researchers had clear theoretical pathways for how to develop drugs further, which was not true about neuropsychiatry. And I think if you wonder why psychedelic medicine boomed so much and why it was hyped so much in the 2010s, that's part of the backstory. It is that the field of psychopharmacology was in a deep depression exactly at the time when the first clinical trials with psychedelics were launched in the early 2010s and then had positive results. And suddenly it was like, wow, this is the path forward, right? If you look at the literature, they're all announcing a paradigm shift. They're all saying, we're done with this biological psychiatry paradigm. It failed. Here is a new path forward. In many ways, development of these neuroplasticity enhancing psychoplastogens, we're basically back to a version of a pharmacotherapeutic paradigm, but with a different explanatory model and betting on different kinds of mechanisms. But the enthusiasm, apart from the drugs driving the enthusiasm, has a lot to do with this historical situation in the history of drug science.
Thank you for listening to this month's episode of Data Nation from the MIT Institute for Data Systems and Society. You can learn more about IDSS and listen to previous episodes at our website, idss.mit.edu, or wherever you get your podcasts. Thank you to our producers, Tina Toby Mack, and assistant producers, Ben Stull and Maria Brooks. Don't forget to leave us a review and follow our Twitter at MIT IDSS to stay informed. Thank you again for listening to MIT's Data Nation.